झालं का? ते TDS केलं का त्यांनी? तारीखाने इथं करू का? सिग्नेचर नाही लिहिलेलं, सील इथं करू.
Dr. Gaurav, we will start the case now. So welcome you all to the 14th IAP PG clinic being held this year. And this is a pre-Diwali session. So in advance, I wish everybody a very happy Diwali. So the presenter is Dr. Gaurav Wankhede, who is a resident from Department of Pediatrics, Kashiba Inole Medical College. And the moderator is Dr. Samir Matre, sir. And we have panelists today. Dr. Anand Deshpande sir is one of the panelists, and Dr. Shiji, who is a pediatric neurologist as DY Patil. She is the other faculty for this session. So, Dr. Gaurav, we can start the session.
Good afternoon, everyone. I am Dr. Gaurav Wankhede from Srimati Kashiba Inole Medical College, third year resident. Just a minute, sir. I'm having glitch. A 14-month-old boy, first born of non-consanguineous marriage, Hindu Maratha, hailing from Satara, brought by parents informing mother with chief complaints of weakness of left upper and lower limb 1 day before admission and deviation of angle of mouth to right side since a day. My patient was apparently all right 1 day before admission when he fell from bed around 2 feet while playing in afternoon, after which parents noticed paucity of movements in upper limb and lower limb in form of not able to hold things in left hand, inability to raise hand above forehead. Parents also noticed reduced movements in lower limb. As per parents, this weakness progressed over next 3 to 4 hours to current state, that is inability to move upper and lower limbs at all. A history of deviation of angle of mouth to right side while crying. Drooling of saliva over left side was noticed by parents. Baby was able to continue speaking bisyllables. There was no history of abnormal movements or irritability since the incident. No vomit.
Before you go ahead, Dr. Gaurav, would you like to give more details about the trauma?
Yeah. So elaborate on the fall.
Okay. So the child was playing on bed up above around 2 feet of height, and while playing, the child fall on head. It was insidious like acute onset, and the complaint started after like 10 to 15 minutes after the incident.
After the fall, whether child had any loss of consciousness, any seizures,
no,
vomiting?
No, ma'am. There was no history of loss of consciousness or abnormal movements and irritability after the incident.
Okay. After how many hours of fall, this hemiparesis weakness noted?
Weakness, parents started noticing weakness after 10 to 15 minutes or
minutes
okay. Of the fall. And
okay.
Yes.
So this weakness was, so how was the onset? Acute onset, and it was progressive over 3 to 4 hours.
Oh, yes, ma'am. Progressive over 3 to 4 hours.
Okay. And how was the weakness? Was it proximal more distribution or distal distribution? As per your description, what is your interpretation?
As per my description, ma'am, parents noticed that weakness was more in distal extremities, but they also noticed weakness in proximal extremities too.
Okay. So how will you describe the distal weakness in an infant?
In an infant, the child will not catch toys while playing, and child will not hold hands of parents while playing.
Okay, so their pincer will be lost.
Yes, ma'am.
So those activities using the pincer grasp will be lost. and less activity, and what will be the proximal weakness history in an infant?
Inability to raise hand above forehead.
Yeah, approaching for objects. If you are giving a toy from above, so with shoulder abduction, elbow extension, that should happen. So shoulder abduction was a main proximal movement here.
Yes, ma'am.
Okay.
So what is the age of the child, Dr. Gaurav?
14 months, sir.
14 months. Okay.
Okay. Along with this, what are the other complaints? One is your weakness. Along with that, you something mentioned about the face, deviation
Yes.
of angle of mouth. What
Yes,
does that
ma'am.
indicate?
It indicates facial nerve involvement, ma'am.
Okay.
And
So
it
there was
was
only deviation of angle of mouth.
Yes,
Any
ma'am.
difficulty in closing the eyes?
No, ma'am. On inquiry, there was no difficulty in closing eyes according to parents.
Okay. Any abnormal movement of the upper limb and lower limb when
No,
they
ma'am.
noticed this weakness?
No, ma'am. There was no history of abnormal movement.
So what are the abnormal movements you expect here?
Like tremors and
No.
or ma'am, convulsion. If there are any convulsion, there can be.
One thing is seizure. Second thing, a dystonia, acute dystonia. Why the infant can have dystonia along with the weakness?
In stage of shock, ma'am. Initial shock.
No. What is dystonia? And how will you elicit dystonia from history?
Ma'am, reduction in tone of muscles.
No. Dystonia means it's an abnormal involuntary movement leading to a persistent abnormal posturing. Right. There is agonistic and antagonistic muscle contraction happening. So
Yes, ma'am.
the child will go into abnormal postures, especially the hand posturing will happen along with the weakness. Okay, this is very classically described in infantile hemiplegia, which is usually missed. It is very transient dystonia and very subtle. On examination only you get, but you can elicit from the history all this abnormal posturing while trying to move. But here you are saying there was no movement at all in 4 hours of time. Okay,
Yes.
what does that indicate? The severity of weakness.
I mean, it was like it was a human lesion. It indicates it was a human lesion.
No, severity of weakness means, is it initially we used to say hemiparesis and hemiplegia. So
yes, ma'am. It was indicated
movement of-
hemiplegia.
yeah, hemiplegia means it's a dense hemiplegia.
Dense lesion. Yes.
So what does that indicate? All these points, why it is important?
In order to localize the lesion, ma'am.
Yeah.
So if there is dense hemiplegia, it indicates more of an internal capsule lesion. And
Okay.
if vertical lesion, there will be disparity in involvement of upper limbs and lower limbs. So
Okay.
like MC-derived infarct, it will be more of a facial and pleural hemiplegia. And
Yeah.
AC-derived infarct, it will be more of facial and brachial hemiplegia. And in AC-derived infarct, it will be more of a pleural hemiplegia.
Okay. In hemiplegia, what is the distribution? Upper limb more affected or lower limb more affected? Usually in MCA
In
territory.
pediatrics, in MC-derived, usually upper limb is more affected, ma'am.
Yeah. If there is association. Yes. Sir.
CG, you can ask. No problem.
Yeah, please carry on, sir, please.
So this is one pattern what you got following trauma. Can you tell us what other patterns you may get? Suppose a baby, an infant or a young child has, say, head injury. What other patterns can you get?
Like, if you suspect a hemorrhagic stroke, it will be more of a catastrophic onset. The child will be irritable and he will keep crying for hours. And there also it will depend on the localization of the hemorrhage, where what all parts are affected. If there is hemorrhage, the child will also have a vomiting and sometimes loss of consciousness.
How will be the progress of symptoms?
In in hemorrhagic, there will in embolic and hemorrhagic, sorry, in embolic onset, all the focal neurological deficit will be present at initial stages only. In a thrombotic onset, it will be a stuttering onset. The lesion, the deficit will go on progressing, and in hemorrhagic etiology also, the lesion will go on progressing, but there will be also subsequent recovery after.
No, my question was little different, Dr. Gaurav. Now, this child had a minor trauma seemingly, and after that, he's had an hemiplegia. So, like this, suppose another child has a fall, what other manifestations can it have? Is what I'm asking you.
It can have a bleeding like ear bleed, nose bleed, and
Okay.
the child may lose his consciousness.
Okay.
He may suffer convulsion.
Okay, so if I tell you that the child, transiently lost consciousness, was okay again, say maybe a bigger child, 2-year-old child, and after 3 days or after some time, after a few hours, had a focal deficit or had a seizure, what would that be due to? So what are the various traumatic brain injuries that you can get following a trauma? So trauma can be either a major trauma or like a seemingly trivial trauma, is it?
Yes.
So what are the various traumatic brain injuries that you get?
Subdural hematoma, epidural
Very
hematoma.
good. So now you are talking, isn't it? Subdural hematoma. So how will that present?
Sir, with features of raised ICT, signs and symptoms of raised ICT, headache, vomiting, and loss of consciousness. And child will present more with focal neurological deficit.
Okay. What else can happen? What is concussion syndrome?
No.
What is diffuse axonal injury, concussion? What are these terms? Dr. Shiji, can you elaborate, please, for the benefit of the postgraduate students?
Yeah, yes, sir. So in concussion injury, because of that impact, there will be transient cerebral edema. So initially, child will be having a loss of consciousness, which might be less than 30 minutes. Usually it is for 1 to 5 minutes. That's in concussion. Might have a seizure, and they usually recover. And usually MRI brain is normal or mild cerebral edema. That's all. There won't be any bleed in concussion injuries, but associated bleeds, depending on the severity, types of bleeds are subdural, subarachnoid, intraventricular, and parenchymal. So depending on the types, the presentation might vary. Subarachnoid, intraventricular are very severe, and parenchymal is also very severe with bad sequelae. Diffuse axonal injury usually seen in acceleration, deceleration injuries. So in severe, usually seen in RTS, road traffic accidents. So that will be usually diagnosed in MRI brain with microhemorrhages and diffuse cerebral edema. And the prognosis is bad. It's classified under severe head injury. So these are the different patterns. And in a head injury case, if you get hemiparesis, the causes can be a parenchymal bleed or a severe subdural hemorrhage causing compression and midline shift. So that's acute TBI induced. But what are the causes of TBI causing a hemiparesis, immediate or later? Dr. Wankhede, a question is to you. If there is a hemiparesis happening within few hours or 2-3 days later, so what are the other possibilities you should think of? It's not directly by TBI.
Ma'am, the dislodging of an embolus can be a reason.
Okay. Anything else? Have you heard about 2-3 entities like transient cerebral arteriopathy?
Yes, ma'am. Transient cerebral arteriopathy and RIND, reversible ischemic neuronal deficit. And
have you heard about mineralizing angiopathy?
yes, ma'am.
Yeah. So all these are very good prognostic causes of hemiplegia, usually seen after minor head injuries. Okay, so one possibility you have to think here is direct TBI induced causes for the hemiparesis, or something like this, like TCAs, mineralizing angiopathy, we should think of. Usually they present after 12 hours to 24 hours or even up to 7 days after the fall. Okay, that's the theory part, but you should keep this in mind. One of the causes of hemiparesis after fall, especially trivial TBIs, traumas.
Okay, ma'am.
Suppose, I give you a history that this is a 14-month-old child and he is having fever for 4, 5, 7 days maybe. And there was some cough also. And then he had seemingly again a trivial fall. And this time he develops a focal seizure and is encephalopathic, and there are signs of raised ICP. So what will you suspect?
Sir, we'll have to suspect tuberculous meningitis and tuberculous meningoencephalitis induced or varicella
Gaurav,
induced.
what is the time period that he mentioned of fever?
Around a week, sir.
Okay,
So,
continue.
Or a varicella induced vasculitis.
What is rich focus?
Tuberculous, secondary tuberculous focus.
Where is it?
In cerebral cortex.
Okay, so what happens with a minor injury? Seemingly minor injury, what can happen?
The displacement of the substrate can cause hydrocephalus and subsequently lead to.
Correct. So sometimes, in some TBMs, you will get this history that there was some minor trauma. So you need to ask this history of fever, Cox contact,
Yes.
other symptoms. These are also important. Okay, and
Yes.
there will be usually an encephalopathy which will be there. This child is not encephalopathic, I think.
No.
Only hemiplegia is there.
Yes.
Okay, all right. Go ahead.
There was no history of abnormal limb movements or irritability since the incident. There was no history of vomiting and loss of consciousness. There was no history of ear or nose bleed, nor any ear discharge. No history of cyanosis and increased precordial activity in the recent past. No history of fever or any rash in the recent past. No history of loose stools and vomiting prior to this episode. No history of easy bruisability or bleeding manifestations in the past.
Gaurav, could you
Please,
elaborate the negative history?
Sir, no history of cyanosis and increased precordial activity points out toward absence of any cyanotic heart diseases, which in itself can result in prothrombotic episodes, a prothrombotic scenario. There is no history of fever or rash in the recent past. Points out more towards varicella and tuberculous meningitis. Absence of varicella and tuberculous meningitis. There was no history of loose stools and vomiting. In infants, dehydration is a common reason for venous thromboembolisms. Do rule out those. No history of loose stools or vomiting. No history of bleeding manifestation or easy bruisability for bleeding disorders. History of trauma near neck or oral cavities. Sometimes a trauma to carotid artery can lead to thromboembolism. No history of Cox contact to rule out a TB meningitis, and no history suggestive of joint pain in past is suggestive of collagen vascular disease.
Okay, Dr. Deshpande sir has joined just now. So can you just repeat the main symptoms? Just tell the age, the main symptoms in short.
Yes, sir. 14 months. Good afternoon, sir. A 14-month-old boy, first born of non-consanguineous marriage, Hindu Maratha, brought with complaints of weakness of left upper and lower limbs 1 day before admission and deviation of angle of mouth to right side since 1 day. Parents noticed that the child was not able to hold things in left hand and inability to raise hand above forehead. Also noticed reduced movements in left lower limbs. As per parents, weakness progressed over next was started after 10 to 15 minutes of the episode and progressed over next 3 to 4 hours to the state where the child was unable to move upper and lower limbs at all. Along with it, there was history of deviation of angle of mouth to right side while crying, and parents noticed drooling of saliva over left side. However, child was able to continue speaking bisyllables.
Okay.
So with this negative history that you just told us, what are the things that you ruled out? What are you attempting to rule out?
Sir, first of all, I'm attempting to rule out hemorrhagic etiology, as the fall may suggest. It is less likely to be a hemorrhagic stroke, and then I was trying to rule out underlying prothrombotic conditions like a heart disease or TB, dehydration, and trauma and collagen vascular.
Any other infection etiology you can think of for a hemiparesis other than TBM?
Very seldom.
Varicella, okay. Anything else? Any bacterial infections? Bacterial meningitis can lead to hemiparesis?
Yes, ma'am, bacterial meningitis.
Yeah. Pneumococcal meningitis, H influenza B meningitis, these are common to cause vasculitis in the severe form, and it can lead to hemiparesis. Can HSV encephalitis cause hemiparesis? HSV encephalitis has been reported as well, even though the presentation is rare. So infectious etiology is bacterial, viral, and mycoplasma is another one, which can lead to vasculitis. Coxsackie is reported. Other than varicella, please remember other infectious etiologies like bacterial, viral. Okay.
Okay.
Can you just summarize? So first thing is it's weakness. The weakness is left hemiparesis with left facial palsy. Looks like UMN because of the eye involvement is absent, upper part is paired. So looks like a UMN facial palsy on the same side of weakness.
Yes, ma'am.
And the precipitating event was a trauma.
Yes, ma'am. We can say it was a trauma. Minor.
Yeah, maybe it might be a incidence as well. Okay. So do you think so? Now you localize, then go to the etiology from the history. You localize to which part of the brain?
To internal capsule, ma'am.
You are localizing to internal capsule
because of presence of dense hemiplegia.
Okay. So if you are localizing to internal capsule, is it ACA, MCA, which artery you are thinking of?
I'm more of ACA, but also more of MCA, but also component involved.
Okay. So can you describe what are the typical pattern in MCA stroke, ACA stroke, and PCA stroke? Just for the benefit of students.
ACA stroke, it typically involves the medial part of cortex, which therefore involves the lower limbs more of. It will be more of a crural hemiplegia.
Which one? MCA.
ACA, ma'am.
ACA, correct.
In MCA territory, supplies more to face and upper limbs, so it will be a brachial hemiplegia involving face and upper limbs.
Very good.
And the posterior circulation will have brainstem involvement.
Yeah. So they usually present with vertigo, ataxia, they can have nystagmus, along with cranial palsies, bulbar dysfunction, depending on the level of brainstem stroke syndrome. So this is the localization. Now coming to the internal capsule, which part of internal capsule you will confirm after examination. In a small child, it's difficult like an adult. We cannot ask a history of hemianopy and all, and it is very rare as well.
But is the presentation suggestive of an infection?
No, sir.
So why we are considering infection as a cause? Because there is no fever, there is no altered sensorium. Child is, according to you, what you are told, the child's sensorium is okay, na?
Yes, sir.
There is no clouding of consciousness.
No, sir.
And there are hardly few hours history. So, primarily, which infection can cause like this? I don't think.
Infection was not
is very
considered, sir.
unlikely. Yeah.
Infection is very
Not-
unlikely. Just for the negative history, we asked sir, that question. What are the causes for hemiparesis secondary to
Yeah.
infection?
So in a similar child, what are the other possibilities? Is what, but this
just,
child,
not in this child, but what you
not in this child.
by the lucid interval, and what is the extra dural hemorrhage? How it presents in a head injury? Have you heard of it? Yes.
Sir, extradular hemorrhage will present with like clouding of consciousness features, and child will be in altered sensorium. And
Immediately after the
after 2 to 4 hours, sir.
okay, and the hemiplegia will occur after that. Yeah, after 2 to 4 hours. At the time of injury, there is nothing. So that interval is called as a lucid interval. So after how many hours after the fall, your baby got this hemiplegia? Or when they notice?
Parents started noticing after 15 minutes of the fall, sir.
Hemiplegia was noticed after 15 minutes of fall, immediately after fall.
Yes, sir. They noticed after 15 minutes, and it got progressed over next 3 to 4 hours.
So immediately after fall, within 15 minutes, the child had a hemiplegia, or after 1 or 2 hours.
Sir, the weakness, the parents started noticing positive of weakness after 15 minutes, which progressed to hemiplegia after 3 to 4 hours.
Okay. So
suppose this trauma was not there. So this is a child without trauma and also without fever. Then what would your differential diagnosis be? So this is an acute onset hemiplegia without fever and without trauma. Then what are your DDs?
It can be either a thrombotic episode or an embolic episode.
But what can cause thrombosis and emboli?
Sir, underlying prothrombotic states, cyanotic heart disease, there is no as such history. We'll have to rule out protein C, protein S deficiency, antithrombin 3 deficiency, and homocystinuria. And we'll have to see for any oral trauma or trauma inside oral cavity. And according to sir presentation, it was.
Is a sickle present like this?
Yes, sir.
Can a sickle present like this?
Yes, sir. Sickle will also present like this. Yes, sir.
One more thing you should remember. We saw a child who had this was about 4 or 5 years ago, who came to Sassoon PICU with a history of minor trauma and had an IC bleed. It was not hemiplegia, and there was they had not noticed any features of hemophilia. So sometimes hemophilia can present first time as an IC bleed. It's not common, but sometimes it can happen, and without any joint bleeds and without any family history and nothing. So that also you should remember. But sickle you should remember. Sickle is very important. So how do you want to describe or you want to summarize your case?
Yes.
How will you summarize this?
He was a 14 months old child brought by parents with complaints of paucity of movements in left upper limb and lower limb after a trivial fall, along with same side seventh nerve palsy, probably a human type of palsy with no other associated features.
Okay.
A child was admitted to SKNMC next day after referral from a local hospital, was monitored for a day in ICU, neuroimaging and necessary investigations were done, started on medicines and physiotherapy, and was having gradual recovery in the form of some improved activity since last 3 days. In past history, there was no history of any similar complaints of weakness, easy bruisability or bleeding after trivial trauma.
Could you elaborate on any similar weakness episodes? Why did you ask this thing?
Sir, in case of any underlying vasculopathies, there can be recurrent TIA episodes. So we'll ask that. Also in conditions like hemophilia, there will be easy bruisability and bleeding after some trauma. And in underlying prothrombotic states, also the recurrent TIA episodes can occur.
Maybe there, may not be there. So this could be the first presentation of a protein CS.
Yes.
So this you'll come to know only after testing, isn't it? Okay.
Birth history, baby was full term, normally delivered, cried immediately. There was...
Sorry to interrupt. One just point to add.
Yes,
in any child with stroke, not in this age group, usually a bit later, posterior circulation stroke, the vertebral artery dissections are seen, very rare, but one of the history you will get is after wrestling, after some physical activity in which you have a stretching at the shoulder and neck stretching. You have added that for the carotids, but for cervical artery dissection also, this question is important, just to add that point. And they might get a recurrent stroke.
Okay.
Even in MRI, you might get a silent stroke previous one and a fresh stroke now, and child will be in ICU. They are usually presenting with posterior circulation stroke symptoms with altered sensorium, and child will suddenly progress into coma. Just to add for the completion of stroke. Carry on.
Okay. History. Baby was full term, normally delivered, cried immediately. There was no history of NICU stay, but birth weight being 2.6 kg.
Gaurav, can there be some symptoms or some etiologies which could be attributed to the birth history?
No. Sir, birth history related, there can be history related to congenital heart diseases. If subsequently there is any history of NICU stay, there can be factors further sepsis like umbilical veins catheterization, which can lead to thromboembolic episodes in near future.
Will it present at 14 months of age? Something that happened in NICU, presenting as a stroke when the baby is 14 months old. You can have portal hypertension after catheterization. That is okay.
Sir, in HIE conditions, sir, hypoxic mechanocephalopathy can lead to hemiparesis or hemiplegia, which will be noted.
Yeah, but that won't present at 14 months of age acutely, isn't it?
Yes.
The insult has happened in the neonatal period, so it will present much earlier, isn't it? Not first at 14 months. Okay, so previously the child was healthy. There were no such episodes and no neurological abnormalities were noticed. Is that right?
No, sir. No, sir.
Go ahead, proceed.
There was no significant family history or any family history of blood transfusions in siblings. Child was immunized till 9 months of age according to national immunization schedule. Developmentally, gross motor milestones achieved neck holding at 3 months, roll over at 5 months, sit with support at 6 months, without at 9 months, stood with support at 11 months, and baby walk with support at 13 months. Fine motor attained bidextrous grasp at 4 to 5 months of age, unidextrous at 6 months, immature pincer at 9, mature pincer at 12 months. Cooing was achieved at 3 months, monosyllables, 6 months, bisyllables, 9 months, 1 to 2 words with meaning at around 13 months. And social around 2 months, recognized parents at 3 to 4 months, stranger anxiety at 6 months, waved by at 9 months, and played simple ball game at around 13 months. Looks to be a developmentally normal child. Dietary history, expected calorie requirement was around 1060 kilocalories, and there was deficiency of 375 calories and protein deficiency of 4.5 grams. So socioeconomically, the child belonged to upper lower class. Anthropometry wise, weight of child was 8.2 kg, which was between 1 to -2 standard deviation for age, 4 kg. Length was 70 centimeters. Length for age was -2, which lies between -2 to -3 standard deviation, and 50th center being 76.5 centimeters. Was 44.5 centimeters. 50th center being 46.6, mid centimeter. And thermometrically, child was between median to -1 standard deviation.
Any significance of height or length of child and in children with stroke?
Ma'am, in connective tissue disorder like Marfan syndrome, the child can be tall and which is known for vascular malformations.
Malformations and dissections. Homocystinuria is another one in which you can have a tall stature and prothrombotic. It's prothrombotic. Yeah.
But length is quite short.
Yes.
Length is very short. Parents are short. Hello.
Yes, sir.
Are the parents short? The length is 70 centimeters only at 15 months.
So the weight seems to be less affected than the height. That is why sir is asking you.
Sorry.
But
recheck the height again. Maybe.
okay, go ahead.
Go ahead.
Summarizing the history, 14 months boy with paucity of movements on left upper and lower limbs with a deviation of angle of mouth to right side, acute in onset with no history suggestive of encephalitis, meningitis or raised ICT.
So you located the anatomy. You said the anatomy is ACA plus MCA territory. What is the pathology here?
Sir, pathology is a cerebrovascular accident, sir.
Yes, but what type of cerebrovascular accident? Is it a bleed? Is it embolic? Is it thrombotic? Hemorrhagic? What is it?
Sir, it more
vasculitis.
Sir, it is more like an embolic episode than a thrombotic episode. Because though the symptoms progressed over 3 to 4, but the weakness was persistent like since beginning only, starting of the episode.
What's the difference between embolic, hemorrhagic, and thrombotic? You described it, but say it again. Do you think it's still embolic?
Ma'am, hemorrhagic episodes will have a catastrophic onset, and the weakness will be increased and gradually.
What type of onset? Here, what is the onset of? How was the onset? It has progressed. It started, noticed, and it progressed over 3 to 4 hours from a paresis to plegia. So there is a progression seen. So do you think that is seen in hemorrhagic?
Yes, ma'am. Progress is seen.
No, it is
there will be
catastrophic and it will not
yeah,
improve.
catastrophic.
Yeah.
Catastrophic.
It will be very bad at onset only. It will be very bad.
Yes, ma'am.
You see, adults, no, they are very bad at onset. Hemorrhagic stroke.
Yes. Child will present with headache, vomiting, loss.
Yeah, there will be other signs of raised ICT as well.
Ultrasensorium will be in, unless it is very small bleed,
Yeah.
ultrasensorium will be part of it.
Prominent, yeah.
Yes.
In embolic episode, the weakness will be persistent at the onset of stroke only. In thrombotic, it will be more of progressive, but here as progressive just 3 to 4 hours, and the child was active, playful before the onset. I think it may go more in favor of embolic.
Okay.
Okay.
Is thrombotic possible here, or you think it is not possible?
Yes, sir, definitely possible.
I would still keep thrombosis as a possibility.
Yes, thrombosis should be kept in the DD. So when you summarize, first thing is the localization. First thing is hemiparesis. Then go to the localization. Then go to the etiology. Is it arterial or venous? If it is arterial, then is it thrombotic, embolic, hemorrhagic? Then go to the etiology. This is how you have to summarize and go to the DDs. Even from the history, you can summarize it. Then after examination, you come back to a few DDs. Okay, confirm your findings. So I will include here the anatomical localization, exact etiology, arterial venous, then in arterial, thrombotic, embolic, then again, what is the cause for that? Is it trauma? Is it any prothrombotic condition? Or do you think is it infection? So that way you have to come to a DD. Clear?
How will venous present, Dr. Sameer? Dr. Gaurav?
Venus will present with features of a convulsion, encephalopathy, raised ICT.
Okay.
There will be altered sensorium, vomiting,
Yes, ma'am.
excessive irritability, yeah,
Yes.
seizures.
Yes.
Madam, is there a possibility that the hemorrhage should always be a catastrophic? Can it happen over a period of time?
If it is a,
Usually it is catastrophic because acute bleed into the parenchyma. Slow bleeding sources
If
less
there is not a
likely in
parenchymal
a
bleed
child.
and still infarct.
Yeah, it can be. It can be an extra axial and it is progressively increasing and causing a compressive focal neurological deficit. That's possible. Yeah, 4 hours bit past.
Yeah.
Yes.
On general examination, the child was afebrile, heart rate was 110 per minute, respiratory rate was 30 per minute. Blood pressures were 96 by 56 mmHg, mean 76 mmHg, which were between 50 to 90 centile. Tits and femorals were well felt. All peripheral pulses were well felt. Pallor was present. There was right side deviation of angle of mouth was observed on crying. There was no clubbing, cyanosis, lymphadenopathy. In head-to-toe examination, anterior fontanelle was open at level of size around 1 centimeter. There was no facial dysmorphic features, no neurocutaneous marker, skull and spine normal, no petechia or rash.
1 second. In head-to-toe examination, just the significant factor, not in this case, in general, any child with hemiparesis, what all things you have to look for. One thing, dysmorphism. So what is the significance of dysmorphism in a child with hemiparesis, acute hemiplegia, or recurrent hemiplegia?
I mean, in microcephaly, we can suspect any
Any genetic syndrome which is more prone for any vasculopathy?
Sturge-Weber syndrome.
Okay, but they don't have a dysmorphism.
Dysmorphism, Port-Weinstein.
Any common genetic syndrome, chromosomal abnormality, prone to have moya. Down syndrome. Okay, so just to sensitize you, so Down syndrome prone to have moya. So they can have recurrent stroke, TIAs and stroke episodes. Turner, again, prone for moya. Any neurocutaneous markers important in head-to-toe examination?
One is Port-Weinstein for Sturge-Weber.
Yes.
Cafe au lait spots for neurofibromatosis.
Very good.
Another.
Yeah, very good. And you have to look for, so not in this case, I'm just telling the stroke approach. So if you have any clues for the collagen vascular disorders, so cutaneous laxity, joint laxity,
hemaarthrosis,
fragility, marfanoid features, that should look for. And next thing is collagen, the autoimmune disorders like SLE, those spectrum of disorders in which you can have vasculitis. Okay.
What about eye examination in this child? Is it important to look at the eyes?
Yes, sir. In order to look for papilledema, and
will you expect papilledema in this child?
No, not in this child. In general,
in this child, what do you want to see? In the eye specifically, what do you want to see in this child?
Sir, leash nodules.
Sorry?
Leash nodules, he's saying. Leash nodules are present in which?
Okay. Where will you see leash
nodules? Are present?
Neurofibromatosis.
Where do you see for the leash nodules?
In iris.
Okay. Have you seen any time?
No.
Or you read about it or you have seen it?
No, didn't see any.
Have you personally seen list
No,
nodules?
No, sir. No, sir.
So they are very tiny nodules, and torch has to be tangentially placed to see them. Generally, otherwise, generally we throw the torchlight from front, no? So they are not very well seen. But not very common.
Also, for Marfan's, we'll look for ectopia lentis. This subluxation of lens.
Okay. What? Which important
where else will you get
marker you have
subluxation?
forgot to tell? Important.
Where else will you get subluxation apart from Marfan's?
You didn't speak about tuberous sclerosis. What is it? It's one of the common neurocutaneous marker, no?
Yes. In ash leaf macules and tubers, axillary macules.
Okay.
What about homocystinemia? What happens to the lens?
Sir, also in homocystinuria also there is ectopia lentis.
Yes. So what is the difference between Marfan's and homocystinuria? Which one is upward, which one is downward?
Marfan's is upgoing, sir. Ectopia is down. Homocysteine is downgoing. It's upward and temporal, superotemporal.
Correct. Okay. Go ahead. Tell us your examination findings.
Systemic examination findings. In higher mental function, child was sitting comfortably in mother's lap, conscious, playful, oriented to mother and following mother's commands of mother. Was able to speak to one or two words with meaning. In cranial nerve, first cranial nerve could be examined. In second nerve, Menas reflex was present. Normal pupillary reflex was present. Fundus examination was normal. In third, fourth, and sixth nerve examination, there was no squint or ptosis, and pupillary erections were normal. Normal conjunctival and corneal reflexes were present, and pain sensations for bilateral cheeks were normal. In seventh nerve examination, there was deviation of angle of mouth to right while crying, while child was able to close both eyes properly, and some drooling of saliva was seen to from left angle of mouth. Child responded to sounds, and gag reflex was present, normal tongue movements were present. In motor examination, there was equal bulk in bilateral in both upper and lower limbs. There was hypotonia noted in both upper and lower limbs on affected side, whereas the tone on right side was normal. Power in left side had reduced by 5, where in right it was more than or equal to 4 by 5 everywhere. There were no involuntary movements noted.
So Dr. Gaurav, before you proceed, normally UMN lesions we know are associated with hypertonia.
Yes, sir.
And here you have hypotonia. So are you sure this is upper motor neuron, or you think this could be lower motor neuron?
Sir, actually, the reflexes were all exaggerated.
No, we are talking about tone. We are talking about tone here.
Sir, it can still be an upper motor neuron palsy in the stage of cerebral shock. Still to recover.
Okay, all right. In stage of shock, you could have hypotonia, and later on you will have hypertonia. Go ahead.
Superficial reflexes.
Madam, stage of cerebral shock, how many days can it persist?
Actually, it might persist for few hours to few days to even months and years reported in spinal shock and all. So there is no upper limit, but usually few hours to days, 3 to 4 days, sometimes 1 week. Then they evolve into spasticity.
Thank you.
Superficial reflexes. Corneal and conjunctival reflexes were present. Abdominal reflexes.
Madam, whether that depends on the severity of the original the
Yes,
insult.
yes. Yes, sir.
Insult,
Yes,
the
sir.
insult is more, the
Severity,
longer the
severity more. Yes, sir. Yes, sir. If there is a big
the insult, the
malignant
severity is more.
malignant infarcts might take time to evolve into a spasticity. They might persist in the hypotonic stage for some more time compared to a small basal ganglia infarct. Yes, sir.
Can we say that the prognosis is poorer for recovery?
Yes,
if
yes,
there is
sir.
a longer hypotonic phase.
Yes, long the evolution from hypotonic phase, the cerebral shock into the spasticity, the sequelae and the is more and prognosis is bad.
Superficial reflexes, corneal, conjunctival, abdominal, and cremasteric were normal. Plantas were bilaterally upgoing, the extensor plantas. Deep tendon reflexes. On the affected side, biceps was brisk, triceps, knee, and ankle were all brisk. On the right side, all the deep tendon reflexes were normal. There was no clonus observed. There was no autonomic dysfunction in this child. Child was able to perceive pain sensations bilaterally in both upper and lower limb. Such sensation was present. Posterior column examination couldn't be done. Cortical sensations couldn't be examined, and there were no cerebellar and meningeal signs. CVS examination was normal, and RS and per abdomen examination were also within normal limits.
Okay, you can summarize, yeah.
Okay. 14 months boy with acute left-sided hemiparesis with left-sided 7th nerve upper motor palsy, likely localized to right internal capsule, probably due to a cerebrovascular accident due to thromboembolic injury. This will be my diagnosis.
What do you think? From where should be the thrombus should have come here? Possibilities.
I mean, one is heart disease possibility from patent foramen oval or an infective endocarditis less likely here.
Yes.
Another is underlying of arteriopathies like Moya disease.
More than Moya, you should be thinking of the transient cerebral arteriopathy.
Transmission.
Okay, TCX. So transient cerebral arteriopathy can present after such traumas or a mineralizing angiopathy because child is completely normal, no altered consciousness, not encephalopathy, no seizures yet.
No, ma'am.
Okay. How will you differentiate a cortical stroke and this deep basal ganglia stroke clinically, history-wise and examination-wise?
Cortical stroke will present with seizures, convulsions, and there can be altered consciousness, and basal ganglia stroke will not with convulsion or anything.
Yeah. Severity of weakness, which will be more in
cortical.
Internal capsule.
Internal
It's
capsule.
densely
Cortical.
packed, so the weakness severity will be more there, and cortical it will be usually a paresis. How will you go ahead now?
Ma'am, I would like to do MR angiography first, as I'm
Deshpande sir, any more questions from examination?
Directly how we are going to MR angiography?
Yeah.
You want to do a hemogram or not? This child is having pallor.
Intestinal sickle.
Yes, sir.
Yeah, you have first you do a hemogram, peripheral smear, Pickling test.
या केस मधनं एवढं शिकल तरी पास झालं शिकल.
Yes. Child has pallor.
शिकल एवढं शिकल तरी पुष्कळ झालं. Because MR angiogram is going to show what has happened.
Yes.
And etiology, if you know, you can prevent recurrence.
Yes.
Yes, sir.
So you should be behind the preventable causes should be come to your mind first as a doctor.
Yes.
So what preventable causes are there, I would look for them first. Rather, it is for establishing diagnosis, MRI angiography.
Yeah.
We'll
Gaurav,
do
start with the basic investigations first.
Yes, ma'am. I would like to do a hemogram with peripheral smear, sickling test, and D-dimers, and prothrombin time, and a protein C, protein S after 6 weeks, and homocysteine levels.
Do you know why you wait for a few weeks, 2 months before you do the protein CS? Why not do it immediately? The parents want an answer now only.
Sir, they get used up in the process, in the ongoing process, so their values are spuriously less when we do at the same time.
Very good.
And
Suppose there is thrombocytosis, you do a hemogram and the platelet count is 9 lakh, 10 lakh. I don't know what is the platelet here.
4 lakhs.
4 lakhs. Okay, suppose it is 9 lakhs. Then the child has a hemoglobin of 6 or 7. Okay, there is severe iron deficiency. MCV is 50. You do a ferritin, it is 10. And the platelet is very high. So will that have any significance in this child?
Yes, sir. Iron deficiency anemia in turn leads to causes increases stickiness of platelets, which results in prothrombotic states. Platelet clump formation. It encourages platelet clump formation.
I think directly the etiopathogenesis, I think Dr. Shiji will tell us more. Directly as a etiology, it is not established, but it is a risk factor. Am I right, Dr. Shiji?
Yes, sir. Exact pathogenesis are not explained, but all studies have described, even pediatric and adult studies have described a strong association of anemia, especially iron deficiency anemia and stroke incidents. Other than hemolytic, hemolytic has got direct. One thing is sickle cell, and even TAL has got an association with moya. So that is different. But iron deficiency, strong association. Yes, sir.
Would you not like to do echocardiography?
Yes, sir. Yes, sir. I would like to do an echocardiography. Yes.
And generally, Doppler of the major vessels, especially carotid Doppler, along with that. If there is not in a 1 year old, but older child, you may have any problem in the carotid, so you can want to see, because directly it will go to the internal capsule. Anything that use carotid.
So ANA and APLA levels.
What is the importance of why in cyanotic heart disease there is more hemiplegia? Cyanotic congenital heart disease.
In cyanotic heart disease, there is right to left shunt. During usually the filtration mechanism for infections is major filtration organ is lungs, sir. In cyanotic heart.
That is for abscess you are telling.
Yes, sir.
I'm asking for in which year they have more thrombotic episodes, and which year they have, beyond what year they have more abscess.
Abscesses are found later, sir, like after an year or.
Okay. So thrombosis, thrombotic episodes, why they occur?
Due to hyperviscosity and polycythemia.
Hyperviscosity and polycythemia. Okay. So what, as a pediatrician, we can do for that? Because primarily for routine care, the patients will keep on coming to us. For surgery, it will go to the cardiologist, and for for routine URTI, LRTI, they will come to us. So, as a pediatrician, what is our duty towards the cyanotic congenital heart disease?
Sir, we we would like to see if there is any underlying iron deficiency anemia and prevent that, and use.
Again, it's a very standard question. How do you know the iron deficiency anemia in a heart disease who has a hemoglobin of 17, 18?
On investigations, sir, peripheral smear, see microcyte.
Peripheral blood smear, yes. So you will give our duty towards the congenital heart is to look for the PCV. If it's too much PCV, you can bleed them. It is beyond very severe polycythemia, ranging beyond 60. You can bleed them, or at the same time, you can give iron on whether iron is going properly. Whenever they come to you, you have to see whether iron is going for them, because they need routine supplementation of iron to avoid thrombotic episodes.
Okay, sir.
Iron and folic both are important, so you make sure that they're getting IFA. Okay.
Okay.
Now, why? Because even suppose there is some hemolytic anemia, not only cyanotic heart disease, it's important to give folic acid, because in hemolytic anemia, why do you want to give folic acid?
Sir, it is like folate is used for.
It's a sickle cell disease. Sickle cell disease, you give folic acid. Why we give folic acid to sickle cell or thalassemia?
It is required for cell membrane maturation and development.
So a lot of cells are being produced, no? A lot of cells are being produced, and to produce those cells properly, you will require folic acid.
Yeah.
Do you require for cell membrane, or you require for something else?
Yeah, it is not required for
nucleus
membrane. It is for
nucleus.
DNA.
DNA, B12 and folic acid, both.
Folic acid.
And nucleolar maturation.
So this was the child on the 4th day of admission. Hemoglobin was 11 gram%. Sites were 10,000. Platelets was 4.1 lakhs. Hematocrit 28. MCV 70. 5 MCSC 38. RW 17. Peripheral smear was suggestive of normocytic, normochromic, few microcytic and hypochromic.
So, 1 minute. Just we'll learn on this. MCV was normal for that age?
Slightly on lower side, sir.
Okay. And what do you mean by RDW?
It is red cell distribution width, sir. It is the measure of variability in cell sizes.
Very good. The measure of anisocytosis. Correct. So it will be more in iron deficiency or less?
More in iron deficiency.
Okay. And less in what?
Thalassemia, sir.
Okay, correct.
Hemolytic disorders.
Okay.
Sickling test was negative, and PT, INR, and APDT were normal. The dimer was 0.3.
Do you know how sickling test is done? Which is the chemical that is used for doing sickling test? This will be asked in exam because it is supposedly to be done in the side lab, according to nobody does now, but according to this is supposedly side lab test. That is a sodium metabisulfite you put over the blood, and after 20 minutes you see the slide. Okay.
We read about sickling, early sickling, late sickling,
Yes.
Read about sickling test. It's very commonly asked and freshly prepared solution used.
And it is asked because it is supposedly to be done by the residents and the side lab of the ward. That's why it is asked. Nobody asks you how to estimate bilirubin. What are the tests to be done in estimate? PBS reading and urine protein and sickling, these are basic tests. Urine sugar, these are supposedly to be done. Maybe after 10 years, the NMC will change the norms, but they are supposedly to be done inside lab.
Okay.
That's why they are asked. Go ahead.
This was a diffusion weighted MRI showing a right internal capsule infarct, and this was a flare image in.
Okay.
That's all, sir.
So can you tell us a little bit about diffusion weighting and flare imaging? Where is it done? Why it is done? Because this you are going to see often these terms, isn't it? So you should know a little bit about what is flare, what is diffusion weighting.
Sir, diffusion weighted is done in early periods, like in first 3 to 4 hours. It shows the progression of edema and progression of infarct. And flare helps to differentiate between the pathology and surrounding edema. So like
Gaurav, actually, this one is not a flare. This is T2 weight sequence in which you can see the CSF as white. Okay. And diffusion along with the ADC, apparent diffusion coefficient images, and the diffusion images, diffusion weight images, DWI, are used to find out infarcts in which you will see diffusion restriction. Means the previous image, just see take the previous image. So here it is hyperintense, means more white. Hyperintense part will be seen at the infarct area, and same area will be hypointense or more dark in the ADC. So that means there is a diffusion restriction, and it is the sign of infarct in MRI, and it is seen usually after 2 to 4 hours of infarct, and it might persist for 5 to 7 days, but not after that. It peaks at 72 hours and slowly decreases and disappears by 7th day. And flare and T2 shows this hyperintense areas on the same area. So this is a T2 weight, so in which you will see the infarct as hyperintense, and it is involving the basal ganglia, caudate nucleus, and the putamen lentiform nucleus and the internal capsule. It's not isolated internal capsule. Okay, the right basal ganglia is affected along with the internal capsule. So what could be the reason for this entire affection? So which artery, MCA, which branch will be affected?
Lenticulostriate branch.
Striate branches. Have you done MR angiography?
Yes, ma'am. The report is actually printed available, ma'am.
Okay.
Which was just subacute infarction in right corona radiata in the right gangliocapsular region with small area of hemorrhagic transformation and mild mass effect.
Okay. Angiography not done. This is MRI report. Okay. In angiography, you have to look for any narrowing of the vessels.
There was it was not just of any narrowing or aneurysmal presence.
Okay. Okay. Have you done CT brain in this chat?
No, ma'am.
Okay. Now, why I'm asking that question?
We discussed one disease before just now, which can be present at this age, and following fine minor trauma, they can come with hemiplegia. So what will CT pick up that MRI will not?
And if diffuse axonal injury.
No. MRI will only pick up diffuse axonal injury.
Subdural
CT
hematoma.
normal.
Anything
no.
that is all
MRI
in
is good. MRI is good.
calvarium is not very well seen in the MRI. Any
So you're
impact.
mineralizing arteriopathy. Yeah, mineralizing arteriopathy. You're looking at calcification will not be seen well in MRI.
Yes.
And similarly, the skull bones
Yes.
and any impact over them, any fractures,
Yes.
they will not be very well visualized. Bleeds are better visualized in the
CT.
CT. So, but generally for those adult programs which intervene in a hemiplegia by thrombolytic therapy, they use CT as the primary modality. Am I right?
Yes, sir. Because of the bleed as a commonly seen in adults, to find out the bleed, CT will be the first thing, and they have to thrombolize.
And they have to do basically time required is also.
Yes, see, the first 6 hours is very important. Yes, sir.
And scanning time is MRI would take at least 30-40 minutes
Yes.
complete,
Yes, yes.
which will be vital in that.
Dr. Shiji, what is your experience with pediatric? Anybody does thrombolysis or
No,
these
sir. Actually, there
interventions?
are there are few
thrombectomy?
studies. There are few only clustered studies, no randomized controlled studies for this thrombolysis and all. The latest AHA guideline is not advising any thrombolysis or thrombectomy in pediatric age group. But there are isolated case reports from Europe and US. But that's done usually after 8 years of age, not less than that. And tissue plasminogen activator, all those usage.
Yeah.
Even newborn
After 8 years.
case reports are also there, but it is not advised.
All right.
Yes.
Would there been any advantage in doing MR spectroscopy in this case, Dr. Shiji?
MR spectroscopy, sir, in those cases, the
Typical
stroke,
presentation.
yes, sir. Stroke mimics in MELAS. The MELAS is a mitochondrial cytopathy, which is usually seen towards a bit later age group, in which you can look for lactate peaks. Second, metabolic strokes, usually seen in propionic acidemia, methylmalonic acidemia, in which we can have specific peaks in MR spectroscopy. So these are the conditions which we do MR spectroscopy. So stroke-like presentation, they are stroke mimics.
So, but if it is available in the same machine,
Yes, sir.
It is better to advise or do
usually in such acute stroke, usually no, sir. I usually
Okay.
don't. Yes, sir. If it is like a stroke-like episode recurrently happening, so recurrent stroke-like episodes, yes. Yes.
because it requires nothing for the
Yes.
from the point of view of
Mhm.
you have to just order. It increases some cost by some. If that software is there, the cost is little bit increased. That's all.
Yes, yes. In routine stroke cases, usually I don't advise, sir. In atypical cases, yes, definitely yes.
So how will you manage now further?
Sir, with suspecting thromboembolic episode, we can start with low molecular weight heparin early, and then we can continue with aspirin for as long as up to 2 years. And
So how many days you will use this low molecular weight heparin? When will you switch to aspirin? What dose will you use?
Sir, low molecular weight heparin will be given by 1 gram per kg per day.
1 gram per kg. 1 gram per kilogram?
Yes. 1 milligram per kilo.
Yeah. Okay.
And we'll continue for 5 to 6 days, and we'll see for we'll do PT and INR levels, and once we achieve
So can you monitor your low molecular weight heparin by doing PT-INR? Is it possible to monitor?
no sir, APDT levels.
No.
APDT
So even APTT will not help. PT or APTT will not help if you are giving low molecular. What will you do? What test actually can monitor a low molecular weight heparin?
D-dimer.
It is not PT APTT. What will you do? What test will you do? That we don't routinely do. In COVID, people, everybody used a lot of
D-dimer.
hexane. No, so anti-factor
Pro
10A
test.
is a recommended test. Yeah, anti-factor 10A is the recommended test for monitoring. Okay. Low dose when you give, it does not change your APTT. You have to do anti-factor 10A levels to monitor it. That routinely nobody is doing. Okay, and then aspirin, what dose will you give?
3 to 5.
Yes, and you will continue for up to 2 years, you said.
2 years.
Okay,
What
any
are
other
the-
treatment you want to give? Yeah.
Yes. Gaurav, how will you decide whether to continue low molecular weight heparin or to convert into warfarin and to give for prolonged period? That means antithrombotic therapy in which all stroke cases.
Ma'am, if you're suspecting any embolic manifestation, or we can directly start with the warfarin, and if he has like embolic manifestation and underlying thromboembolic states, we are suspecting, then we can directly start with warfarin. Or we are suspecting a thrombotic scenario, then we can start with low molecular heparin and then switch.
All cases of stroke, unless it's hemorrhagic, you start with low molecular heparin, give for 5 to 7 days, then converting into or overlapping with a warfarin and continuing that was decided by the etiology. Sometimes we won't find any etiology. If you are sure of the etiology, like as you said, thrombotic conditions like protein C, protein S deficiency, antithrombin 3, so definite diagnosis, but usually not done within 7 days because we don't do within 7 days. Okay, so recurrent stroke might be a hint for that. Then complex congenital heart disease, cyanotic heart diseases. If it's a cervical, posterior circulation stroke with vertebral artery dissection. So all these are the indication for long-term
Anticoagulant
prophylaxis. This is arterial. In venous, cerebrovenous sinus thrombosis. That you have to give for minimum 6 months. Okay, so and find out the reason for CVST. Okay, so if it's a venous thrombosis, ideal this thing is.
Do you still use warfarin or the better drugs for that?
Yeah.
Because
What are the newer drugs? Yes.
because warfarin has so many drug interactions, that's why I'm asking.
Yes. The newer drugs, Gaurav, can you name newer drugs used as antithrombotic? Have you heard about dabigatran?
Dabigatran, yes.
Rivaroxaban?
Rivaroxaban and anti-thrombin inhibitor.
Yeah. Dabigatran is antithrombin inhibitors, antithrombin agents, and rivaroxaban is anti-factor. Yeah. Good. So these are the new drugs with less drug interaction, less burden for monitoring of all these PTINR and all. Yes, sir, please. Deshpande, sir.
Yes, that was only my question. Because it is a long-term use, there are a lot of drug interactions are there.
Yes, sir.
What will be the prognosis in this child? What will you tell the parents?
Prognosis will mainly depend on the etiology. That parents accordingly, like, we'll have to go into etiology first. For now, we'll have to just continue treatment and see.
Is it likely to have good prognosis, bad prognosis? Is there a threat to life? What kind of disability you may have? What will you tell? See, you can't just say that We don't know yet, isn't it? So what will you tell the parents? Is there a threat to life in this child? Whenever you are asked prognosis, first is threat to life. So do you think this child is a threat to his life currently?
Currently, he doesn't will counsel of not having threat to life as of now.
Okay. Then
there can
what
be
about
recurrences.
okay, there could be recurrences, and you will give medicines to try and prevent those recurrences. That is your counseling. Third, will the child walk? Will the child able to go to school? Will he be able to run? Will he able to do a job? Will he able to drive? What will you tell? All these questions will be asked, no, to you.
Sir,
Will you tell?
yes, sir. Sir, the activity can be internet. The activity can be resumed after regular physiotherapy or for years. Like it can take time for a few. It can take a long time, but there are good chances that activity can be resumed.
Okay, so one setting you cannot generally give prognosis for these children, isn't it? So what you say is that in most children there is recovery. Okay, and a lot of things can be made clear on follow-up, because at one time you cannot declare anything, isn't it?
Yes.
Many things are not clear right now, isn't it? So
Yes.
when will the facial nerve palsy, get better? When will the hemiplegia get better? When will the child be able to walk? Okay, all these things cannot be told now.
Yes.
So you will have to say that this is a disease that will evolve, and it will depend on how the child, how the nature responds or how the child responds to your treatment. And therefore, a lot of things could be told only on the follow-up. Okay. So you cannot give out prognosis one time in neurological conditions mostly.
Okay,
But at least the parents should be made to believe in physiotherapy, which they feel it won't be helpful at all. So they should be made to believe the physiotherapy will be helpful.
Yes, absolutely agreed. So physiotherapy is important. So you have to tell them, it is as important as the medications you are giving. So yeah, counseling needs to be done about that.
Yes.
Dr. Shiji, anything you want to add to the discussion that we did?
Yes, sir. The chance of recurrence. Parents might ask about the chance of recurrence, whether this can happen again. So, Gaurav, what is your point of view on that? Any idea? How will you counsel on that? Sir asked many questions. So, one more addition. What is the chance of recurrence if parent asks you?
There are definitely chances of recurrence, ma'am. As long as um, until and unless we don't do the we don't know the underlying etiology, be sure of the any lesser chances of recurrence. There are always chances of recurrence.
Don't counsel high chance of recurrence. There is a 30 to 40% or 25 to 30% chance of recurrence. So there is a possibility of recurrence. That's why you are giving the antiplatelet, antithrombotic, whatever you are giving us for prevention of a recurrence. And maximum chance of recurrence is next 6 months, and maximum limit is 2 years. That's why you are giving for 2 years of antiplatelet therapy. This is how you have to counsel why you are giving for 2 years. So we are expecting a recurrence in next 2 years of time. So continue this medication for 2 years. Okay, continue physiotherapy, and rate of recurrence, as Rajesh correctly said, the rate of recovery will be individualized, and physiotherapy and stimulation, developmental therapy will definitely help in the recovery. Okay.
Yes, ma'am.
Yeah. So your presentation was good. Just to, in summary, always remember to summarize, localize, etiology, step 1, 2, 3, differentials, examine, confirm again your findings from the history findings in examination, and come to a conclusion. Okay, so here the thromboembolic or thrombotic, what looks like, to me it looks like thrombotic here. It is arterial. And again, you need to do the further workup to confirm the cause of this thrombosis. Okay. Deshpande sir?
Right. Nicely presented.
Very good presentation, Dr. Gaurav.
Thank you, sir.
Yeah. So thank you very much. If there are no, Dr. Deshpande sir, you have any questions for Dr. Gaurav?
I don't have a question for CG. How many
Yes, sir.
cases? How many cases do you find etiology in your experience?
Etiology, sir.
In how many cases you are able to pinpoint etiology? And
Yes, sir.
how many?
Recently, yeah, maybe 50 to 60%, sir. I'm able to get the findings recently because we are doing the further studies with MR angiography and CT and DSA. So maybe because of that, the vasculitis diagnosis, the primary CNS angiitis, we are able to diagnose recently, other than the common causes. Protein CS and all very difficult because even if after 3 months we do, the report is normal. So few cases are undiagnosed, definitely. 40% no etiology, sir. 60% we are getting it recently, all cases. The mineralizing angiopathy, TCS are the latest diagnosis, we are adding it to it.
Okay, okay.
Yes.
Question for Rajesh. Rajesh, after COVID, did you see increased incidence of this?
Yeah, so a lot of
Definitely.
not hemiplegia per se, but there were a lot of neurological issues that came up post COVID.
Yes.
And I remember one child who had come from DY Patil.
Yes.
That child had a stroke. Yeah, that
Yes,
child
sir.
had a stroke, who recovered completely.
Yes.
So yes, it is, I think, very much post COVID. It is known that these kind of things can happen.
Yes, sir. Dr.
Yeah,
Samir, actually, yes.
adult have a lot of studies. There is definite
Yes.
increase in the
Yes.
CVA. They have a lot of papers where
Yes.
at least DMH has 3 to 4 papers made out of the post-COVID increased incidence of hair.
Yes. So from DY, we have a paper which is presented recently in ICNA Turkey. 57 cases of neurological complications. And out of that, 7 had stroke. And out of them, 2 had cerebrovenous sinus thrombosis. So CVST was seen.
Most of them are probably immune-mediated post-COVID
Yes.
antibodies which are causing problem. So MISC cardiac became very famous, but I think CNS, it is less compared to the cardiac problems, it is little less, but
Yes.
definitely it is not. So in
Yes.
fact, a lot of pancreatitis, we got a lot of type 1 diabetes, protein manifestations. Now the problem is whether to blame COVID or was it a bystander? That is the difficult part
Yes.
in COVID. So because everybody is COVID antibody positive, so that's a problem that is there.
That's there, sir. Yes.
Right. So if there are no further questions, I think we can end this session. Very nicely presented, Dr. Gaurav, and very nicely mentored by Dr. Samir. And I thank both our faculty, Dr. Deshpande sir with his experience and wisdom, and Dr. Shiji ma'am with her knowledge. Thank you very much for being here today. And post Diwali, we are planning a session. The dates are not yet finalized, but I think it is Dr. D.Y. Patil Medical College who would be presenting a case next. So thank you very much for attending, and
Thank you,
I
sir.
think we'll end the meeting here. Thank you very much.
Thank you, Rajesh. Thank you for giving us this opportunity. Thank you.
Yes, sir.
Thank you.
Thank you, sir.